Good evening. I hope it's a beautiful day in Philippines, and here in Italy we are quite busy with the COVID epidemic. As an infectious disease physician, we are really busy with a lot of patients with the new epidemic, with a very new disease for us, especially a systemic disease. We have a lot of patients with different complications, with a lot of comorbidities, and we have, unfortunately, a lot of young people with quite severe disease. Today, we're talking about stewardship, a stewardship perspective. We will be talking about the possibility of integrating new antibiotics into a stewardship perspective. Of course, there are no general rules for the new antibiotic use in patients with a variety of infections, but we can try to see together which kind of systems, ideas, let's say guidelines, papers, and personal opinions we can try to use to highlight how in a daily clinical practice we can see and understand a general problem, which is the use of new antibiotics. We can try to use a very simple history. Unfortunately, it may be a common history in our big hospitals. A 28-year-old man admitted to the ICU for polytrauma after a road accident. In the past medical history, he only has insulin-dependent diabetes mellitus, and the only is quite different depending on the contemporary situation of the disease. In the emergency room, he was intubated and mechanically ventilated. He was transferred to the ICU and did have surgery within the first 6 hours due to extensive trauma and need of orthopedic surgeries, external bone fixation. After 6 days, the patient was still mechanically ventilated, was having abdominal discomfort, abdominal distension, low-grade fever, and the empiric antibiotic treatment, the ongoing empiric antibiotic treatment was kept on with piperacillin tazobactam and vancomycin. As we see, most of our patients may be well fitting into a clinical vignette of a patient, of physicians, of medical assistants. In this picture, you have no mechanical ventilation, but you have a patient, his comorbidities, the contemporary medical history, we have treatment, antibiotics, and so we are left with a clinical assessment of a stewardship program, of a stewardship perspective, especially with the underlying conditions, neutropenia, renal function, age, bacteria and susceptibility, pharmacology, and time-dependent versus concentration-dependent antibiotics. Of course, hypovolemia, fluid amount, source of infection, type of inflammatory response, and a series of considerations about drug availability. So the choice is on the type of drug, on the dosages, on the type of administration. And we see also another problem by a clinical perspective. We see the problem of the differential diagnosis. Differential diagnosis with the distended abdomen may well be on intra-abdominal infections, within primary and secondary peritonitis, within biliary and extrabiliary disease. We can remember this patient had extensive surgeries, but orthopedic surgeries. We did not record any sign of direct abdominal trauma, even if the type of accident was a high-energy road accident. On the other side, we may use within the differential diagnosis nosocomial pneumonia. We can see the heart rate, temperature, blood pressure, and respiratory rate within our 6th day of hospital admission. So in the differential diagnosis, we may see pulmonary or abdominal, physical exam, no signs of pneumonia, chest X-ray, bedridden, chest X-ray was negative, abdominal CT scan, diffuse hypotonia of the small bowel. We kept ongoing with piperacillin tazobactam and vancomycin. After another 48 hours, after another 2 days, acute onset of fever, 38.6 centigrade, hypoxemia, increased need for ventilator support, left lower lobe infiltrate, increased respiratory secretion, and of course, at this point, the differential diagnosis was more on the side of pneumonia. So a very good action is take samples for microbiology, either invasive and non-invasive culture, either quantitative and or qualitative culture. Excuse me, this was Siri going on. We had some microbiology from our patient with tracheoaspirate taken for cultures, plenty of PMN, polymorphonucleoside, polymorphonuclear cells, gram-negative bacilli. This patient was not known to be colonized by KPC producing Ebbsella, although it is quite endemic in Italy. Rectal swab were performed the day before because this patient was not a high-risk patient coming from the outside, coming from the community. So the first screening in our country was kept on day 7. CPIS, clinical pulmonary infection score higher than 6. Which empiric antibiotic treatment may be followed for ventilator-associated pneumonia? We can see the European guidelines versus the IDSA, Infectious Disease Society of America guidelines. We can see also diagnostic versus treatment. So we see how within the IDSA or the European Respiratory Society, the definitions and the clinical definitions and the clinical, I would say, time zero of our diagnostic and treatment efforts is within clinical criteria alone to decide whether or not to initiate antibiotic treatment, not using CPIS to guide the discontinuation of treatment. So in America, our colleagues, in my opinion, are right. If you have a clinical picture consistent with pneumonia, you may use clinical criteria alone. We had fever, we had worsening of sputum, we had the left lower lobe infiltrate, we had polymorphonuclear cells in tracheoaspirate, we have gram-negative rods, and we have a worsening of respiratory function and the need for improving ventilatory support. Within the European Respiratory Society, we have CPIS for the acknowledgement of the term low probability of hospital-acquired pneumonia with patients with low scores, clinical pulmonary infection score, or a clinical presentation not highly suggestive of pneumonia at symptom onset. So on the American side, we are more on the side of sensitivity of diagnosis. Here, we recognize the term low probability of hospital-acquired pneumonia, and we should work on a side, on an effort of specificity of diagnosis. Then the American says hospital-acquired pneumonia and ventilator-associated pneumonia are different. Our colleagues from Europe say hospital-acquired pneumonia and ventilator-associated pneumonia are quite similar with a series of considerations. All these series of considerations are true and appropriate for the antibiotic stewardship of pneumonia, for the stewardship of nosocomial pneumonia, for the stewardship of nosocomial pneumonia versus ventilator-associated pneumonia. And risk factors for multi-drug-resistant bacteria are within the prolonged hospital stay, recent admission, previous treatment, local prevalence of multi-drug-resistant bacteria, and multi-drug-resistant bacteria colonization. All of these should be considered while we are trying to treat our patients empirically within the best appropriate time frame and effectiveness of our antibiotic treatment. So within the European Society, Respiratory Society guidelines, all those patients with a low MDR pathogen risk and low mortality risk, so within patients without septic shock and without MDR pathogen risk, you can see here the value of antibiotic monotherapy. Then within no septic shock, possibility of having a single gram-negative agent active against 90% of gram-negative bacteria in the ICU, you can try to find a single anti-gram-negative active against 90% of gram-negative bacteria in the ICU. And here you have some patients, high MDR pathogen risk, high mortality risk, and septic shock, which will receive dual gram pseudomonal coverage. Our patient is young, diabetic, after 1 week of hospital admission, I should say 8 days of hospital admission, with respiratory worsening, so we'll need dual gram positive, dual gram negative coverage. So within our case presentation, we should try to see how the empiric antibiotic treatment was given with linezolid, ceftazidime-avibactam, gentamicin, with our results consistent with Klebsiella pneumoniae KPC producing after 1 week of hospital stay. Unfortunately, in Italy, carbapenemases produced by Enterobacteriales are mostly KPC and not OXA48, sensitive to ceftazidime-avibactam, gentamicin, colicin, cotrimoxazole. Rectal swab, also this patient was colonized by KPC Klebsiella. So within our empiric antibiotic treatment regimen administration, we did use double gram-negative coverage, anti-pseudomonal coverage, and linezolid. The de-escalation rule was made at day 3 when we did know that there was KPC producing Klebsiella. So unfortunately, this is a history of precocious colonization and invasive infection by KPC producing Klebsiella in a European country. Now, what's the stewardship point of the old and new antibiotics? Because on the side of ceftazidime-avibactam, we could use, for example, meropenem. We could use piperacillin-tazobactam, although this patient was already on piperacillin-tazobactam. We could use other new anti-pseudomonal agents, but we could also use ceftazidime, cefepime. We know the amount of limited effectiveness of gentamicin and aminoglycoside within the lung tissue. So let's try to see how the epidemiology and microbiology of Enterobacteriales is due to the mobilization of carbapenemases resistance. There is a dramatic increase of carbapenem-resistant Enterobacteriales. Carbapenem resistant is often mediated by new carbapenemases like KPC. We did have a dramatic increase in the Italian epidemiology in the last 10 years, OXA48 or metallo-beta-lactamases. Both of these are consistent and within the avibactam activity, but the new daily metallo-beta-lactamases are outside of the avibactam ability to restore ceftazidime sensitivity. Then we have unique epidemiology, unique microbiology, and there are a series of infection control programs that can be improved just to understand how the epidemiology is, how the epidemiology may be somehow mixed in our country, maybe somehow mixed in our hospital. So now we can say that in Italy, even if the most of the problem is KPC, we have a few cases of OXA48 within Enterobacteriales. We have few cases of new OXAs within Acinetobacter, for example, 163, 181. We have new epidemics of metallo-beta-lactamases. And these central issues to be understood are on the microbiology side, on the genetic side, but also on the infection control, I would say, land on the infection control perspective, just because most factors contributed on the global dissemination are unknown. If we take the example of colistin, the MCR1 colistin resistant gene was first found outside of the hospital, so we did erroneously attribute colistin administration to the emergence of MCR1 gene. Then there is another problem. If you look at Public Health England, and if you look at the heterogeneity of these different carbapenemases or carbapenem-resistant genes, then you will see that metallo-beta-lactamases, yellow, orange in BIM, OXA48 green, KPC blue, may be quite commonly detected even within different hospitals in the same city, let's say London, even in the same hospital in the same city, of course. So the new perspective is just to have a very quick view on the heterogeneity, on the resistance to carbapenems within our country, within our local epidemiology. We should not forget ESPL production, extended spectrum beta-lactamases production, extended spectrum beta-lactamases heterogeneity, just because the efficacy of piperacillin-tazobactam, ceftazidime, and cefepime may be somehow residual. We all know the Merino trial, that the Merino trial did show a 4% mortality with meropenem against a 12% mortality within patients having bloodstream infection and definitive treatment with either piperacillin-tazobactam or meropenem. We all know that the Merino trial was not a perfect trial, that there were a lot of biases, but the consistent efficacy of meropenem against piperacillin-tazobactam is also strongly reducing the effectiveness of cefepime and ceftazidime to patients with clinical stability. Better is having urinary tract infections, better is having urinary tract infections without any obstruction. Then you have the efficacy of carbapenems, like meropenem, the old imipenem cilastatin, or the new doripenem, and the new beta-lactam with beta-lactam inhibitors, like ceftazidime-avibactam, like ceftolozane-tazobactam, or even meropenem-vaborbactam. So within all of these, global epidemiology, molecular epidemiology, we can try to fit the new antibiotics. Then we can try to answer this question: how frequently do you try to understand the possible presence of carbapenemases, either by a clinical, epidemiological, or stewardship perspective? Clinical, it means we try to understand it, we try to adapt our empiric treatment accordingly. Epidemiological, we try to fix in our mind how many bacteria with multi-drug resistance mechanisms are found within our hospital, within our city, within our region, within our country. Or by a stewardship perspective, because here the key is changing level of clinical and scientific attitude. So we can answer never, sometimes, only with treatment failures, only within the stewardship team, only with microbiologists in the stewardship team. If we try to vote for this question, we can try to answer by different levels of being interdisciplinary with our colleague, being interactive, being a clinical, a physician, being a microbiologist, or being pushed toward the stewardship perspective. Then there is another point. If you feel you can be attracted by an antibiogram, by the antibiotic sensitivity, then Enterobacteriales, Pseudomonas, and Acinetobacter can have different enzymes. We can see KPC and OXA48. We can see BIM and DM within Enterobacteriales, but of course within Pseudomonas aeruginosa. We can see GES within a variety of gram-negative bacteria. Let's see the KPC hydrolysis, extended spectrum hydrolysis of beta-lactam with high MICs for carbapenem. Whilst if you look at OXA48, the hydrolysis of carbapenem is higher and more consistent than the hydrolysis of ceftazidime and cefepime. You can have lower MICs for carbapenem as compared to KPC. So sometimes here, even in front of clinical failures to carbapenems, you may try to remember that you may be facing the problem of OXA48. Ceftazidime and cefepime are possibly active, but sometimes you will be in front of bacteria with co-presence of extended spectrum beta-lactamases and OXA48. So you have complex phenotypes, while you have strong carbapenemases activity of metallo-beta-lactamases, but the aztreonam will be active sensitivity of aztreonam against metallo-beta-lactamases. So, and these other enzymes, less known, less described, but they have a lower activity against aztreonam and imipenem. I'll show you one point. If you fit within the one looking at meropenem sensitivity or resistance, MICs of meropenem and carbapenem, and OXA48, then within a series of patients, even with carbapenem in the range of clinical sensitivity, you can see how the administration of a drug with in vitro sensitivity may be associated with a bad outcome. So it's not only a question on sensitive or resistance, it is also a question of heterogeneity, genetic heterogeneity behind the enzymes which is associated with carbapenem resistance, because it is a carbapenemases. Would have the management been different with a negative rectal swab for KPC Klebsiella pneumonia for our patient? Yes or no? It depends. No, if a carbapenem sparing strategy is employed. So if we are within understanding global epidemiology, molecular epidemiology, if we try to look at the clinical perspective, a microbiological perspective, or a stewardship perspective, then most of clinical studies, for example, of ceftazidime avibactam, were made against the carbapenem. So you can use either empirically or somehow less often within a targeted treatment ceftazidime avibactam because you are sparing carbapenem. No possible low sensitivity of the rectal swab. So within our swab capability, we cannot say that the method is 100% sensitive for detecting the KPC colonization. Yes, I would use carbapenem or other antigram-negative drugs, which is a very good answer. I am not using only the new drugs. I am using the old drugs. This patient was coming from piperacillin tazobactam administration. We can try to be different within our understanding of antibiotic treatment. And let's see the main criteria leading for this new antibiotic in the empiric setting. You have the same concept. You have clinical entities, differential diagnosis, abdominal versus lung, UTI versus another infection, especially bacteremia. You have risk factors for carbapenemases or for ESBL producing bacteria, because the ESBL producing bacteria may well be within strategy of carbapenem sparing. You have different criteria, broad spectrum antibiotic treatment, history of prolonged hospitalization or long-term chronic care facility, invasive devices, immune suppression, local epidemiology, outbreaks. You have a septic patient, you have a signs of invasive disease, you have comorbidities, especially immune suppression, lung, heart, or elderly patients, neoplastic disorders. You have local epidemiology, carbapenem resistant higher, Enterobacteriaceae higher than 20%, ESBL producing Enterobacteriaceae higher than 20%. Within all of these descriptive slide, you can have the reason for a carbapenem sparing strategy. Then the empiric recommendations should be variable according to the different site, hospitals, and country recommendations. And we have real world data in addition to the registration papers and registration data where ceftazidime avibactam was mainly compared to carbapenem, either in those studies with within the comparison with the best available treatment, BAT, the 90% of best available treatment were given meropenem. So in most of the registration trial and papers, ceftazidime-avibactam was compared to carbapenem. While in all of these, you can see that the real-world data were made with CRE pathogens. We have real-world data from the USA. We have real-world data from Europe. We have real-world data within Italy, the Italian study. We have here 76 patients, mostly 2/3 treated with monotherapy. We have the Italian experience with ceftazidime-avibactam. Let's look at how many patients on the total number did have positive blood culture. And all of these were patients treated with ceftazidime-avibactam. Ceftazidime-avibactam compassionate use after 1 week. So they had to survive with the old antibiotics given before, mostly within colistin, meropenem, tigecycline, or aminoglycoside combination regimen. And we can see how within the Italian experience with ceftazidime-avibactam, the only variable associated with a good outcome, so with survival, was the presence of ceftazidime-avibactam, and I would say of ceftazidime-avibactam, either monotherapy, either combination treatment with ceftazidime-avibactam. There is also another point, the combination treatment or monotherapy. In this patient, given the disease, given the combination treatment, given the immune suppression by the diabetes, the precocious colonization by KPC producing Klebsiella, we did see and did administer a 10 days total antibiotic duration regimen with combination treatment for 1 week. Now, this is the point of de-escalation, because we cannot talk about stewardship perspective without talking about de-escalation strategies within our hospital. We did know that in most of papers, there are different strategies of de-escalation. In patients with nosocomial pneumonia, ventilator-associated pneumonia, complex diseases, complex invasive infection, the best strategy is a composite strategy, when de-escalation is a composite strategy made of clinical, microbiological, lab or biomarkers, and timing. In our experience, within our stewardship perspective, within our stewardship programs, we are not only pursuing de-escalation by one of these factors, especially in patients with emergency medicine or critical care medicine. And we are trying to de-escalate as soon as possible, not before day number 3 or day 5. Sometimes we are left with the question of spending on new antibiotics or spending on the fast-track microbiology. We can try to use both to quickly improve the appropriateness of antimicrobial regimens as soon as possible on the side of adding antibiotics or here de-escalating antibiotics. So also reducing the antibiotic spectra or reducing the number of antibiotics given to our patients. So another question may be, what's the preferred way of de-escalation, of de-escalating? Clinical, microbiological, biomarker-driven, composite de-escalation. I will bet that most of my colleagues and probably most of our friends, physicians, will try to be consistent on the side of de-escalation, especially because they are trying to get more data to safely reduce the number of antibiotics and safely reduce the antibiotic spectrum of activity for our patients, just because we understand that the reduced antibiotic spectrum is associated with reduced microbiome disturbances for our patients, therefore our hospital. So in conclusions, we have evidence-based recommendation for selected patients with pneumonia on the assessment of risk factors for multi-drug resistant pathogens. We have ceftazidime-avibactam, and we have plenty of data for ceftazidime-avibactam, either in pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia, REPROVE trial. We have data within intra-abdominal infections, RECLAIM trial. We have data for urinary tract infection, RECAPTURE trial, and we have data against the best available treatment in patients with ceftazidime-resistant, in patients with infections by ceftazidime-resistant bacteria. Then extensive real-world evidence from the USA and Europe against carbapenemasis producing bacteria, KPC and OXA48. Let's remember that avibactam is not restoring the activity of ceftazidime against metallo-beta-lactamases. We can try to remember that criteria leading to the empiric choice of new antibiotics may be identified on clinical grounds, plus local epidemiology, perhaps molecular epidemiology. And the combination of the availability of the new antibiotics extensively compared with carbapenems, the activity versus ESBL-producing bacteria, carbapenemasis producing Enterobacteriales strongly suggest new stewardship approaches. Within the new stewardship approaches, a great chapter is given by the carbapenem sparing strategy. There are several algorithms proposed for the management of patients with fission of ESBL, carbapenem-resistant Enterobacteriales, Pseudomonas, Acinetobacter, and of course also gram-positive bacteria. You can see how within these ESBL, CRE, Pseudomonas, and Acinetobacter, you can see how these boxes are fit to contain new antibiotics, but also carbapenem. So a very good piece of antimicrobial stewardship is to try to adapt in the empiric setting and in targeted setting of antibiotic treatment carbapenems against the new antibiotics. There are examples of carbapenem sparing strategy where there is no carbapenem-resistant Enterobacteriales with possible escalation strategies. The possible escalation strategies will include piperacin tazobactam with clinical stability, intra-abdominal or urinary tract infections without obstruction, ertapenem only in patients without severe sepsis, without septic shock, without risk for Pseudomonas aeruginosa, and without ICU admission, ceftazidime and ceftazidime within clinical stability, urinary tract infections without obstruction, community-acquired infections, monotherapy with gentamicin or amikacin for UTIs and clinical stability. There are examples of carbapenem sparing strategies where there are no carbapenem-resistant Enterobacteriales. Let's see high-dose tigecycline in community-acquired intra-abdominal infections. Let's see also ceftazidime and tazobactam within specific time frames and diseases. Let's see the approval for intra-abdominal UTIs, hospital-acquired pneumonia, and ventilator-associated pneumonia in patients that may be treated with ceftazidime-avibactam with specific epidemiological data. We also may conclude with the other examples of carbapenem sparing strategy within local epidemiology consistent with OXA48 or KPC. Here, ceftazidime-avibactam is the main drug. We can see in the future the activity of meropenem vaborbactam against KPC, but not against OXA48. And we can try also to see how very good papers have been published on the antimicrobial stewardship perspective on how the core elements of antibiotic stewardship programs may be well fit for infectious diseases physicians, microbiologists, infection control officer, and hospital administration, as well as for the pharmacists and for all our medical doctors and nurses with a very good attitude on interdisciplinary approach. So we can try to use all of our best diagnostic and treatment efforts in the best perspective of interacting with microbiology, infection control officers, pharmacy, and of course, all of our colleagues within our hospital team under a big supervisor, which is represented by the local epidemiology and perhaps the molecular epidemiology. Thank you for your attention and my best regards from Italy.
Good afternoon. Okay. Hello there. Good afternoon, everyone. I am Dr. Mafi Taizon. I will be your moderator for this afternoon. I'm also an infectious disease specialist. And of course, before we present our questions to our dear speaker, I'd like to introduce our esteemed speaker. We have Dr. Francesco Giuseppe De Rosa. Hello, Dr. De Rosa. Good afternoon.
Hello, can you hear me?
Oh, yes, we can hear you.
Okay, good morning.
Dr. De Rosa is the Associate Professor in Infectious Disease of the Department of Medical Science in the University of Turin, Italy, and also the Director of Infectious Diseases at the City of Health and Science in Turin and Asti, Italy, Regional First Opinion in Infectious Diseases and Solid Organ Transplant. Good afternoon, Dr. De Rosa.
Good afternoon.
And thank you very much for that wonderful talk, because now we know that we do have other options, especially when we are faced with drug-resistant gram-negatives. Maybe to start, I can look at our Q&A and see if we have some questions. Okay. Maybe I can, Dr. De Rosa, perhaps I can give you my the first question. Here in the Philippines, our ESBL rate is 50% in the community. And among our very sick septic patients, we usually opt to start meropenem. So in our scenario, do you recommend carbapenem sparing regimen? And I know that you have discussed that, but most of our patients having this drug resistance is also in HAP and VAP. So it's in hospital-acquired pneumonia. So with that kind of ESBL rate, would you have can you kindly give us some thoughts on how to approach any carbapenem sparing strategy that we can use?
I didn't understand, I'm sorry. How much is the percentage of ESBL resistance?
53%.
53%.
That's right.
So in this setting, you can evaluate carbapenem sparing strategies also in the empiric setting, or you can try to use fast-track microbiology to have a diagnosis as soon as possible. In other words, if you start a carbapenem and you have the possibility of reducing the time to the correct microbiological diagnosis, if you can spare 1 day of carbapenem for each patient, then at the end of the year, you are using a carbapenem sparing strategy. The carbapenem sparing strategy is not only using alternative drugs like ceftazidime, cefepime, combination treatment with aminoglycoside or fosfomycin and beta-lactams, new drugs, let's say other combinations in biliary infections other than urinary tract infections, but also on the side of reducing the amount of carbapenems used and administration during 1 year or 6 months.
Okay, thank you for that. I do notice that also carbapenem resistance is also a problem in Italy. Is that also, am I correct?
Yes.
And
unfortunately, it's a problem.
It's a problem. Yes. Here in the Philippines, the carbapenem-resistant strains of Enterobacteriales is also increasing. And based on your experience there, there's one question here from one of our colleagues. He said, do you think we should use ceftazidime avibactam as an early targeted treatment for suspected gram-negative infections?
We can use ceftazidime avibactam following some rules, which are kind of, I would say, medical rules. Epidemiology, local epidemiology. Usually the amount, the threshold is around 20%. Carbapenem-resistant Enterobacteriales, yes or no. But of course, this 20% may be hospital-wide, maybe in specific wards, maybe for specific site of infections, let's say urinary tract infections more than bloodstream infections. So it's a kind of understanding how the local epidemiology of carbapenem-resistant Enterobacteriales is going on in our hospital, or in such a big hospital like City of Health and Science in Turin. I should try to understand how it is on the southwestern versus southeastern part of the hospital, in lung and heart transplant versus kidney and liver transplant wards. So I can use ceftazidime avibactam. I try to be on the side of local epidemiology, and I would say in our hospital, most of Klebsiella colonizing and infecting patients, if carbapenem resistant, 95% are KPC and 5% are OXA48. Most of E. coli carbapenem resistant, very few percentage, those are VIM. So there is no way that metallobeta-lactamases may be overcome by metallobeta-lactamases may be overcome by the new beta-lactams. So it's a kind of understanding where are you working, which are risk factors, which is the syndrome, which type of microbiology you have in front of you, and how much delayed is the correct diagnosis. And of course, we can try to fit ceftazidime avibactam, like all the other drugs, in the empiric setting, with all our personal efforts in doing so.
There's also a question here regarding what's so special about avibactam. What is its difference with, for example, tazobactam and other kind of beta-lactamase inhibitors?
Avibactam is a new, I would say new, but it was developed by AstraZeneca, if I well remember, 10 to 15 years ago. Is a new diazo-bicyclooctane component capable of giving reversible inhibition of beta-lactamases, including KPC and OXA48. Class A and D, not including metallo-beta-lactamases, so like VIM, for example. So within the new chemical structure, diazo-bicyclooctane, you have a specific inhibition of new beta-lactamases like KPC and OXA48 with a reversible mechanism of action, which says, it's like to say, chemical experts say they, even if it is changing the chemical structure after the first binding to the beta-lactamases, it still is able to bind to a second beta-lactamase. And this is a new way of inhibiting beta-lactamases, since clavulanic acid and tazobactam are suicide inhibitors. Once they bind, they are lost.
Okay. So I think I'm just going to check if there are any other questions. Can it be given as a continuous or extended infusion? Dr. DeRosa?
Ceftazidime is capable of extended infusion. The avibactam component, there is no specific suggestion on extended infusion, but let's say that the standard is a 2-hour infusion, 120 minutes infusion 3 times per day. And the pharmacokinetic of avibactam in the lung compartment is proportional to the ceftazidime component.
Okay, I think, okay. With, I think that should be our last question, Dr. DeRosa. And I can see Dr. Maginsay with us, the overall in charge of the whole convention. Dr. Beck?
Yes, good afternoon. Can you hear me?
Yes,
Yes.
Dr.
Yes.
I can hear you.
Good afternoon. First of all, in behalf of the PSMID board, I would like to thank our speaker, Dr. Francesco Giuseppe Rosa, for sharing your time and expertise with us today. Thank you very much. I also thank Dr. Mafi Tyson, the moderator, for ably navigating the discussion. And of course, Pfizer Philippines, our perennial partner in imparting valuable scientific information through learning symposia like what we just have now. Thank you, everyone. Thank you to all the participants. We hope that you have maximized your learnings from these sessions that we are having in this convention. With that, may I present these certificates of appreciation to our speaker, Dr. Francesco Giuseppe Rosa, for again sharing your time and expertise in our 42nd PSMID Annual Convention, and to Pfizer Philippines for always being our partner in medical education. Thank you very much. Good afternoon, everyone. Please stand by for the plenary sessions that will soon follow.